Our next presentation is by CEHAT. Sangeeta Rege, Senior Research Officer from CEHAT, is going to make the next presentation. Her topic is Implementing a Comprehensive Response to Sexual Violence, Learnings from the Collaborative Program between the MCGM hospitals and CEHAT. The idea of CEHAT was conceived 20 years ago when a group of researchers and healthcare professionals decided to create an alternative health research institution which is at the interface of activism and academics. CEHAT comprises of a multidisciplinary team such as doctors, lawyers, social workers, public health experts, and counselors. CEHAT, through its research, intervention, education, and advocacy, has been addressing issues of right to health care for all, investigating and combating sexual violence, and caring for survivors. CEHAT has pioneered a comprehensive healthcare model in 3 public hospitals in Mumbai, based on standards set by the WHO for sexual assault survivors. Since 2008, the services have extended to over 250 women and children. I welcome Sehat. Sangeeta, please do take over. Also, just a small request. I think it might work better if our presenters address one question at a time, so then we can sort of control how many questions to take. Thank you.
So thank you very much to Foundation for inviting a presentation from CEHAT. Just to give you a brief about what the presentation is going to talk about. This is an experience of having implemented a comprehensive healthcare response across 3 municipal hospitals in Bombay since 2008. So it predates the POCSO and both the CLA. The presentation is really aimed at presenting a profile of children, which are people under 18, the nature of sexual violence that they're reporting. Also bring in, like the previous presentation said, different kinds of health consequences that prompt survivors to reach hospital settings and report sexual violence, but merely for treatment. Also share experiences related to our interface with police, judiciary, as well as public prosecutors and the child welfare committees. And most importantly, speak about components of medical legal evidence and their limitations. Okay, I have to do this and this. So this is just to give a sense of what are the components of a comprehensive healthcare response. This is a collaborative program, like I said, between CEHAT and the municipal corporation. What it entails is training of a cadre of health professionals, which is doctors, nurses, to be able to provide and obtain informed consent. I'm not going to get into the details of each of these components because I believe that this audience is already exposed to those components. So obtaining informed consent, creating documentation of a detailed kind related to the history of sexual violence. When I say that, I mean that doctors are trained to go beyond writing the typical alleged history of sexual assault, but here they're actually defining what sexual violence means. Carrying out a gender sensitive examination and evidence collection, when I say that, what it means is doing away with the finger test, not commenting on hymenal status of children, providing first contact psychological aid. There's an assumption that this is a therapeutic role of doctors, but as we know for many, many years, that doctors themselves are preoccupied with forensic evidence and often don't have any skills for communicating. So this is an element which has been introduced to provide psychological first aid. Their job doesn't end with just evidence collection, examination, and treatment, but it also entails clear and foolproof chain of custody, which means how the evidence is collected, how is it air dried, whether it's stored, whether it's handed over properly to the police, and so on. Because we've heard of many violations in the past about the violation of chain of custody in the very famous case of Delhi, where ultimately there was no evidence which was found, and also referral to appropriate agencies. So this is just to present some evidence on the profile of survivors of sexual violence. From 2008 to 14, we've received about 580 rape survivors. We've divided them into adults, that is people over 18, 18 and above, and children. So if you see a whooping large majority, which is 64%, are actually children reporting sexual violence, which is 370. We have actually made efforts to disaggregate the kind of information and look at elopement and false promise of marriage, separate them from the data set. So they have been provided with services, but one doesn't want to contaminate the information when we are talking about sexual violence. Because in cases of elopement, these children are forcibly brought to the hospital for a medical legal examination, and often they say that we've just had consensual sex. So they are spoken about the importance of treatment, about emergency contraception and so on. and efforts are made to ensure that their agency is respected. That is why it's a separate category. Again, the false promise of marriage does not fall into the classic definition of rape. So we've looked at 321, which is 87% of the children which are reporting forced non-consensual sex. If you may all be aware of a report that had come 1 year back in the Hindu newspaper, which said that a large majority of children reporting sexual assault are in fact consensual sex. And this kind of data actually needs to read back to that kind of information saying that's not true. Because if it's only 13% of people who may be in some kind of consensual sexual activity, but a whooping 87% aren't, and the focus should be brought back on them. So for the purpose of this analysis, I'm going to focus only on the 321 cases of sexual violence. This is just to show the pattern of reporting because CEHAT's work predates the POCSO. So from 2008, when we started working on this issue of sexual violence in a collaborative fashion in the hospitals, what we realized was that almost 37% of children were being brought by the caregivers, which is essentially parents, to the hospital for health complaints emerging out of sexual violence. Post-POCSO, you see a large drop in it, and you see that there is higher reporting now to the police, which is also in a sense good, but it's a sociological issue as well because we need to understand what prompts people to report. Is it the passage of the POCSO? Is it, government policies and norms around reporting? Is it increased confidence after the Nirbhaya episode saying that it's okay to report? We don't have clear answers to it, but there is an indication of a jump in the nature of reporting. Another important factor is around disclosure of child sexual abuse. And I think this is important for several of you who are actually engaged in service provision and you may relate to it. About 31% children have immediately reported about the sexual violence to a caregiver, which is essentially family member or a parent. And I'm sure this is possible just based on the rapport of the child with the parent. But if you look at the other categories, 15% of the perpetrators have actually been caught in the act by a family member. Another 14% have reported some or the other kind of health consequence to the hospital, and it was there that it was found out that the health consequence was a result of sexual violence, which I have listed could be pain in abdomen, could be pain while urination, could be an unwanted pregnancy, and so on. So the health system actually becomes a contact to reveal the health consequence which is out of sexual violence. So this is reading back to Audrey's slide where we know that most of the perpetrators are known, but just a breakdown of known perpetrators. If you look at the column on the bottom, the table here, it shows you that about 46%, which is family and stepfather, are situations of incest. Whereas the others are either neighbor, acquaintances, boyfriend, partner, and so on. So in 238 cases, we know that the perpetrator was a known person. And 46%, 46 number is that related to incest cases. Now, this kind of information is really critical, especially coming from a health system perspective, because we must understand that this entire analysis is from the medico-legal records and the intervention, which is the counseling records of counselors sitting at the hospital. So what do we have to share? Primarily the issue around nature and circumstances of sexual violence. So if you look at the first table, because of the broadened definition of POCSO, which looks not just at penile penetration, but looks at penetration by fingers and looks at non-penetrative sexual violence, if you see 44% children are actually reporting non-penile penetrative sexual violence. And this does require a lot of skill on the part of a healthcare provider to be able to elicit this kind of information. So 44% are reporting non-penetrative abuse. 49, which is 15%, are reporting penetration by fingers. So if you put that data together, the penile penetration is not really the largest category. And that's why it's important to advocate for role of health professionals to be able to communicate with children as young as 2 and 3, to be able to elicit this kind of information and carry out the examination and treatment. The second category is actually looking at what is it that prompted the sexual violence. We all know that sexual violence is an act of power. But how is it that the child actually gets into this, and how is it that the child is groomed? Now, grooming is a long-term kind of relationship that a perpetrator builds with a child. But these are really very different reasons which have been quoted here. One is that 17% children reported that they were lured. This was either with, giving permission to watch TV in their houses if they did not have television, toys, chocolates, money, even time to play with the child. There are some others which have been actually misled by stating that I would give you a job and so on. Then there is a category called who are kidnapped and blackmailed. And the not lured one is 70%. So I think this is important information to be able to put out to say how is it that the sexual violence happens. And this slide would then connect to the kind of medical evidence that one can or cannot find in issues in child sexual abuse. Coming to a critical component of what is medical evidence. So often medical evidence is understood only as some kind of injury, and I think it's time for us to expand and look at what really does the medical evidence mean. So to begin with, medical evidence can comprise of trace evidence, which is either semen or spermatozoa, blood or hair, dust, paint, grass, whatever that's found on the body, fecal matter, body fluid, saliva, etc., which may not be often found, but it needs to be understood as a kind of medical evidence. Injuries, quite obviously, it could also be blunt trauma, it could be abrasions, contusions, lacerations. This is just medical terminology to say that this is how injuries are classified. The other and the third category, which is the health consequence, which could be either HIV, hepatitis, STI, unwanted pregnancies, pain in urination, defecation, and so on. Even stuff like trauma, this is something that needs to be taken into account. And fourth, of course, which I have not listed here, is medical legal documentation carried out by a doctor. So it's possible that the child reports to a hospital much later. So all that there is on record from the doctor's perspective is the history which is told by the doctor, by the child to the doctor. So if you look at the health consequences that have been reported, first, it's important to say that of the 321 cases, 71% children have reported within 4 days, which is 96 hours of the episode. And the 96 hours is crucial because the WHO says 72 hours, you may find some kind of evidence. In the Indian context, the central government has expanded the 72 hours to 96 hours, to 4 days, thinking that probably you may not have literate people who are reaching hospitals. So if there is a gap, 96 hours is our best bet to find some kind of evidence. So what we are saying is that 70% of the children have reported to the hospital in 4 days. Now, if you look at the table below, what you clearly see is that despite reporting within 4 days, less than 1/4 of these children have sustained a genital injury. Even lesser have sustained physical injuries. And that's why if you look at the small other categories, which is the 5, 3 and 5% looking at health consequences, these need to be understood as medical evidence of sexual violence in children. And there is a need to advocate for understanding of these kinds of health consequences. This data and this evidence is in keeping with the WHO standards, where they've conducted a multi-country study in 2003, and they've said that less than 1/3 of survivors are reporting with any kind of genital injury. So this data reads into that kind of evidence. So then what are the limitations of medical evidence? One is that medical evidence rapidly erodes with time, with all activities such as bathing, douching, urinating, defecating, and so on. There is a possibility that in penetrative sexual violence, a condom was used, or despite a condom not being used, there's possibility that semen wasn't emitted. The other thing is, with the expanded definition of POXO, you are not going to find medical evidence in each and every case. So we have to understand that the expansion of the definition will not lead to medical evidence. For example, in cases of masturbation, where there is no emission of semen, you're not going to find any evidence. And that's important to be advocated for. The last point is around mucosal injuries, which are thin membrane related injuries, and they may quickly heal with time. So even if the child is brought into the hospital on the same day, you may not find any redness. Does not mean that sexual violence has not taken place. So I think that's the distinction that we constantly need to make. So what are the learnings from the field? One is that what we've realized is that despite putting our house in order in terms of the healthcare response to sexual violence, having trained healthcare providers, doctors, nurses to be able to put out this kind of evidence, unfortunately the police, the child welfare committees, and the courts have still not awakened to limitations of medical evidence. So it's often looked at as a litmus test that if there is medical evidence, yes, it's a case of rape. If there is no medical evidence, then there is no case of rape. And there is a need to change this kind of understanding across all the stakeholders. So one is that the police are not, like Audrey said herself, are not in tune with the law. So for example, there is very little awareness that a survivor can be brought to the hospital directly without a police requisition, which is now of course come in 2012 and 13 with an amendment in the law. But when survivors, those 30% survivors actually reported to the hospital, police refused to file a first information report, saying that they were supposed to report first to the police station. Second is around the issue of police requisition, that they too come up with a letter, and then the letter to the examining doctor has these kinds of questions which are absolutely unscientific. No doctor on this earth can answer these kinds of questions: whether rape occurred, whether the victim is habituated to sexual intercourse, was she a virgin, whether she is capable of sexual intercourse. These are not the kinds of questions that any doctor in the world can answer. Further, rape is a legal term, so no doctor is allowed to use the term rape. We've also seen that when they are dissatisfied with a certain medico-legal report, children are subjected to repeat medico-legal examination, which has to stop because it's illegal. One is it's illegal, second is it's invasive, and it's just not done. It's unethical. Uh, the issue that we discussed just now was around mandatory reporting. So the fact that a child reports to a hospital for a health complaint and seeks treatment does not mean that she wants to report. So the central government guidelines of 2013 in fact empower the examining doctor to be able to record what is called an informed refusal, which indicates that if a child is brought in and if the child is under 12 years old and the doctor does not suspect a foul play and is convinced that the parent is not interested in reporting, then it's called a terminology called informed refusal, which is recorded in the medico-legal records. Treatment is offered. At the end of the month, what goes to the police station is an aggregate data of 34 children reported to our hospital, out of which 26 have filed or 30 have filed a police complaint. But the details of this child who does not want to report are not sent out. So I think it's important for us also to look at what the law is saying. Is the law saying intimation or is it saying information? So those nitty-gritties are something that we need to look at. At the same time, it's important to document reasons for what is it that prompts parents or survivors to not report. To be able to create some kind of evidence and go back to the lawmakers stating these as reasons for which people don't want to report. So I think it's not enough for us to just say no mandatory reporting, but come out with a set of reasons as to what is it that compels parents, families, caregivers, and children to not report. On the other side, you can see there are efforts made in order to interface with the police. Of course, there are limitations to what we've been able to achieve from it. But we've actually developed an SOP, which is again based on the central government protocol, which says that what is the role of police, what is the role of doctors. So doctors have been empowered to refuse answering police requisitions. All they're supposed to hand over is a filled pro forma. And the police can record an FIR on the basis of the filled pro forma. Efforts have been made to stop even a woman police constable from being in the examination room and being privy to the history that is being sought from the child. So these are some of the norms that we've been able to put in place. The Child Welfare Committee is another important, extremely important component that comes in place, especially with children. We realize that in Bombay, the 3 or 4 child welfare committees which are in existence have varied amount of knowledge and information about the role of health sector, about their own role, and so on. We've realized that whenever there is a case of child sexual abuse which needs to be reported to the police, there is a lot of bias against the survivor, especially adolescent survivors, children over 12 and above. There is disbelief and there is a lot of forced institutionalization. So in terms of crisis interventions, we've actually intervened in individual cases where we've submitted reports saying forced institutionalization can actually be hazardous to the child. So, you're actually punishing the child by taking her away from the home which she considers as safe place. So other efforts have to be made in order to ensure that you're monitoring the child's progress. But we do realize that there is a limitation in the manner in which the current child welfare committees are functioning. They are not aware of the law. It's also this entire moralistic attitude about not letting children out once they are inside the institutions. So a lot of effort really has to be made with the child welfare committees to be able to respond to children's needs. Because ideally, in other countries, when there is reporting, and if there is mandatory reporting, it happens to protection services. In our case, a protection service could be something like a child welfare committee. But the child welfare committee itself is so biased and anti-children that it's hard to make any efforts to put a child in an institution. So I think that's the other thing that we need to learn from the West, that if there is some kind of reporting, and if it's mandatory reporting, should it happen to the law enforcement or should it happen to protection services? And if we are interested in making the protection services work, then we have to all work very closely to really change the perspective of people in protection services. Like I said, that just putting the health sector in order and putting perspectives of the health sector in order is not adequate. We've actually undertaken an analysis of about 14 case judgments in children and adults both. And we do realize that there are lots of gaps in what's happening at the level of courts. So if you look at what are the factors that lead to conviction, uh, trace evidence, if there is trace evidence absent in terms of sperm, spermatozoa and all of that is absent, doctors have been able to explain the reason behind it. And I think that's important, that doctors be equipped to be able to explain why there is no medical evidence. So that has been put in place. So there is this case of a 16-year-old girl who was raped, and she was brought to the hospital within 24 hours. But because she was menstruating, evidence is lost with menstrual blood. So while this case came up to the court for a hearing, and the first thing that the judge asked was that there is no medical evidence, the doctor was able to explain this, and there was a conviction on that account. Also, there is injuries, and there is interpretation of lack of injuries. So for example, if a lubricant was used in a case of a child, you may not find any injuries. Or if it was non-penetrative sexual violence, you may find no injuries. These are the kinds of explanations that doctors need to offer in the court, which has happened. A distinction was made by a doctor in one particular case where there was redness on the labia, there was redness on the vagina of the child, and the doctor was asked to explain the redness. And the judge actually said, is it possible that sexually transmitted disease can occur in a 5-year-old? To which the doctor actually made a distinction and said that if it is a sexually transmitted infection in a 5-year-old, even then it is a reason for us to suspect sexual violence because it's a 5-year-old child. So I think it's also about being equipped as doctors to be able to answer in the court. Oftentimes, doctors are considered as expert witnesses, but that's not how the court treats them. So when they try to explain, they're asked to only answer in yes and no, and it's extremely demoralizing. So efforts have to be actually made at the level of the court and the public prosecutors to be able to present this kind of evidence. Factors leading to acquittal, these are purely because either the doctor was not called to the court, or it was a gap at the level of the public prosecutor who's supposed to engage with the doctor and bring in this kind of evidence. So if you look at the injuries, there was no interpretation for reason related to lack of injuries. The trace evidence itself was not explained. Then when there is offense of non-penetrative sexual violence, evidence of semen and spermatozoa is being asked by the court. Even this clarification was not offered by the public prosecutor. And of course, social factors, we've had at least 3 children who have withdrawn in the age of 14 to 16. They've just not made court appearances. So in those cases, the court anyway is really not interested in prosecuting. And the case dies down its own natural death. So we are at a crossroads really where there is an increasing need to create awareness on not the forensic aspect, but on the therapeutic role of healthcare providers. The fact that health consequences need to be interpreted as evidence, so that recognition needs to come across. And there's also need for building awareness around limitations of medical evidence. Audrey is not here. There was a classic case which was quoted where a 2-finger test was conducted on a child, and to say that the vagina of the child was lax due to being subjected to continuous sexual violence by her father. And the court upheld this kind of medical evidence. So of course at the end of it you have a conviction on record. But the challenge is that would we like medical evidence to be used in this manner? Because in the same case, if there was no laxity in vagina, is the court going to say that it was not a case of incest? And I think these questions, people, groups in Bombay, in Maharashtra, in India, need to start toying and discussing that what ultimately is the role of medical evidence. So I think I have completed before time.